Our next speaker for today is Dr. Zia Saquib, who will be talking about AI in healthcare. And he is the Senior Vice President of Technology, Innovation and Development at Geo Platforms. His primary interests are in the areas of adaptive signal processing, computer vision, and AI. And he applies these areas to develop technology for government to citizen platforms and healthcare applications. He has also rolled out a healthcare AI portal that addresses the gap in rural and remote areas for screening and detection of diabetic eye diseases. Over to you, sir.
Thank you, Ritu. Thank you very much. And thanks to Geo Institute and Dr. Nilay to have me here today. And I'll just give me a minute. I'll open up my presentation. Yeah. So today my talk is about the impact, or rather the use of AI in healthcare businesses. And before I jump into this business of healthcare, just a little bit about our story. How we got into this project and this business. See, for the last 4 or 5 years, our mandate has been to develop technologies and platforms which can bring government services and schemes to the citizens. And when we say that, we meant primarily the citizens who are underserved, people who are in remote areas, who live in rural areas, elderly people, and people who are not able to travel to the city for such service. And we were doing a lot of surveys on what are a list of services which are of paramount importance for these people population. And we did a lot of surveys and a lot of questionnaires and all. I found out that it's okay to bring a platform for government services, but the most important thing which brings the government and the citizen together, rather in one platform, is healthcare. And now we also realize, as part of Reliance and part of this group, that we will not be able to cover every aspect of healthcare. Healthcare is a very deep and broad subject. And where do we start from? I mean, what is the point in talking about healthcare when we are not healthcare professionals ourselves? We are technology people. So how can we leverage technology to bring healthcare close to these people? So after a lot of internal discussion, that there are certain diseases and certain conditions, non-communicable diseases, which are very common. And one of them happens to be diabetes. And I think all of us know someone who knows someone who is suffering from diabetes today. And we know the devastating effects diabetes has on people's lives. And we studied a little bit of diabetes and its complications, and we found that diabetes affects your body, and perhaps the first organ which is visible to the outside world is the pair of eyes. Your eyes, they say, is a window to your soul, but I think it's more than a window to your health, actually, when it comes to such diseases. So our journey began with bringing these services to the citizens, and specifically for diabetes and diabetic eye diseases. And then I'll just walk you through our journey, and I'll show you a small demo then what we've done. Now, we all know that of all the areas and domains in which AI has been helpful, it's been in the forefront, okay? Perhaps. And we use AI in multiple ways. For example, it improves diagnostics, advance some treatments, design drugs, and things like that. But we specifically wanted to do something which is very close to the user. and that would be diagnostics. How do we improve diagnostics and diagnostics of the eye? So all the health conditions, can benefit from AI, and they benefit from AI. And at present, AI is being used to diagnose cancer, kidney disease, and many others like lung disease and all that. But the most prevalent, according to us, is perhaps diabetes and the resultant diabetic eye diseases. You see a lot of people suffering from cataracts, glaucoma, diabetic retinopathy, and things like that. So what is the business objective? Okay, so our business activity is focused perhaps at the intersection of two main goals or other areas. One is use artificial intelligence, and second is leverage public policy for business creation. So there's public policy around health, Ayushman Bharat, and many other schemes which are available to the citizens. Leverage that public policy to create business around healthcare. So there are two parts to it. One is how do we enhance and integrate image pre-processing, computer vision, and machine learning methods for better detection and prediction, especially in image data sets. So because eyes being, an image of your retina, image data sets become very. But AI in diabetic eye care is not only about images; it's also about workflows. And we found from many other projects which came earlier than us. For example, there was a project which was done in 2019 by Google, which is something similar, and we learned from there. We may call it mistakes or learnings. So one is we would like to do a lot of disease surveillance, very early detection and accurate detection of diabetic eye disease. And how do we do that? We take our equipment, our cameras to the remote areas and screen people in community settings. That is one. Business creation. How does all this help in business? This screening business and this business of predicting or detecting eye diseases is done through a point of care offering through general physicians and diabetologists. The first point of contact for any of these people who suffer from diabetes is perhaps a general physician in their locality, or in maybe a bigger town, a diabetologist. Okay. So we have diabetologists who take in these patients and screen them, and we have our backend which does all the heavy lifting. And then we use a hub and spoke model to leverage AI-powered diagnosis for speed and scale. Why do we talk about speed and scale? Is that I'll just come to the business case here. Just 1 minute here. This is a business case. We have more than approximately 150 million people in this country who are suffering from diabetes. Now, out of these 150 million people, 12% develop diabetic-related eye diseases, and some of them have sight-threatening diseases. This number is growing every day, and some people even call India as the capital of diabetes. And there are no symptoms. There are no early symptoms. People may have diabetes, diabetic retinopathy or glaucoma, and they may not even know it till the time it becomes sight-threatening. And on the other hand, we have little less than 25,000 ophthalmologists who can cater to this huge workload. So imagine the ratio of 25,000 ophthalmologists, 150 or 145 crore. It comes down to something like one ophthalmologist in 15,000 people in the urban areas, and one ophthalmologist to 3.5 lakh people in the rural areas. So this is certainly an unmet need. So what we are doing is we are empowering these ophthalmologists and GPs, general physicians, to diagnosis. And this AI-powered automated diagnosis has become a boon for the population. And we believe this at the moment. There are not too many players present at the moment, although the field is growing. And whatever we are doing in this, the medical doctors are very much kept in the loop for any dispensation. So when we are diagnosing anything for these people, the reports are not given directly to the patients. We are not allowed to do that. So we always have a medical doctor who is kept in the loop for dispensation for any treatments. So now coming back to my earlier discussion about hub and spoke. So this is a model which is working in the field, and we'd like to see more people enrolling with us in the coming days and months. So the diabetic eye diseases are, they're for example, diabetic retinopathy, which affects 34.6% or 35% of adults. 40% people who have diabetes will suffer from glaucoma, and diabetic macular edema, CAT, and something called age-related macular degeneration. So all these diseases are very much in the realm of diabetes, and we would like to address all of them through our. So it's a very simplistic diagram here. On the left-hand side, you have an eye which is healthy. You can see the blood vessels. There are no leakages, and there are no exudates or any kind of markings on these vessels. On the right-hand side, you have an eye which is inflicted with retinopathy. You see these tiny blood vessels which are leaking fluid into the retina, and then gradually this becomes turns into exudates, soft exudates and hard exudates, and it spreads, and eventually it becomes sight-threatening, and many people may end up losing the sight completely. So what is artificial intelligence doing for this eye? So there are two aspects to it. One is obviously related to the image. And in my earlier avatar, when I was in the earlier company called CDAT, we were working on some aspects of biometrics and image processing. So it is a very well understood academic field, and a lot of literature which can be used in AI and computer vision. So what is AI doing in diabetic eye care? We can improve accuracy of diagnosis, prognosis, and risk prediction. That is one very obvious change and very obvious benefit of using AI. The second one is on the right-hand side, on the lower right-hand side, is automating detection of relevant findings. Very well proven, extremely accurate, and in many findings, we have seen that AI can do much better than an ophthalmologist. Okay, and I'll show you a little bit. Reduce medication errors, reduce patient visits to the hospitals. Okay. Optimize clinical processes and resource allocation. One of the most critical resource in this particular domain is what we call as a fundus camera. So the fundus cameras, they look very simple, but actually they are very sophisticated piece of equipment and quite expensive. An average fundus camera could cost anywhere between 10 lakhs and above. The cheaper ones are coming now, which can be as low as 5 lakhs. But then even 5 lakh is not very affordable in rural areas. So we try to optimize these cameras. So we try to use these cameras in such a way that to the maximum and do not lie idle in any particular clinic. So we also do identification groups for personalized and precision medicine, so that more precise medicine to each patient. Perhaps on the way, on our new medical knowledge and clinical guidelines, we have not done too much of that yet, but we are in the process, in the journey. And overall, if you look at all these things put together, we improve the quality of care in population health and outcomes. So basically, the idea is to improve the quality of care in diabetic eye diseases and overall population health outcomes, which is also part of the public policy called Ayushman So as I mentioned earlier, optimizing of clinical processes and resource allocation and patient flow. We have this diagram we use. This is one of the cameras which we use in the field. So if you do a better patient's future diagnosis, his risk analysis, we'll be able to afford more efficient treatment and preventive care. And what we do is we club these patients into what we call as diagnosis related groups, severity levels. So we can predict what kind of demand we have in particular geographical areas, and then allocate these scarce hospital resources such as fundus cameras. So for example, if I find that in a place called Ulve, we have a more number of diabetic patients whereas in another area called Udan, we may not have that kind of profile right now. So we rotate and we move these cameras accordingly, and using some kind of algorithms internally, so that these cameras do not lie idle in areas like Udan. I'm just giving examples, but this can be easily utilized to optimize this resource, which is very scarce right now. Now let's come to the image part. Image, we are doing automated findings, automated pattern recognition of these images. So on the left-hand side, you have a typical eye, retinal image of an eye, and there are many key advances. The one is very efficient and accurate search for sub areas. So if you're looking for a diabetic retinopathy, we are basically looking for lesions in the eyes, for example, hemorrhages or exudates, blood vessels which are leaking and things like that. And if you find any such lesions, we can narrow it down using hierarchical methods at multiple resolutions. So we can start with a low resolution, and when we find a region of interest, we can actually increase the resolution to find more details about that particular region of interest. So in our pattern recognition approaches, we have been very successful to detect these areas, such as region of interest for diabetic retinopathy, diabetic macular edema, and glaucoma. Now, automatic detection is paramount importance when it comes to decision which is taken based on very valuable and tiny piece of information. For example, a small dot in your retina, which might be overlooked by an ophthalmologist who was overworked. So you can actually narrow it down to that particular spot efficiently and classify that spot. Okay, and it appears in the latest findings we have found that the sensitivity of AI in such findings is much better than ophthalmologists. And there are papers which are published to this effect. For example, one paper says that the overall sensitivity of a general ophthalmologist is about 20%, and of a retina specialist is about 60%. Whereas AI, the sensitivity can go as much as 96%, which means AI can not only help these doctors and experts, but in many ways it can even be complementary to them. Where these people are overworked, AI can help to actually accelerate and optimize their workload. Now, detection is not only useful when we are talking about a very small piece of information. The detection is also valuable when we are talking about discovering and integrating this information across many patients, which unfortunately does not happen, especially in rural areas. The typical scenario in a rural area would be, the patient walks into a doctor's office, and the doctor diagnoses his disease and gives some kind of a prescription. It could be a medicine, or it could be a small surgery, or something similar, and then he forgets about it, and the patient goes away and then comes back after 3 months, and the doctor opens the file and says, well, have you done this? Have you taken this medicine, and so on and so forth. But there's no correlation between this patient and the patient who's sitting outside, the patient who went before you, or the patient or the other patients in that geographical location. So basically, this part which is missed in today's rural environment is what we are trying to accomplish, is automate or rather integrate this information to many patients and come up with findings which can help us analyze medicines for these people. A typical example is, a patient today visits a doctor once in, let's say, once in 2 or 3 months. And while he's away from the doctor, he does not know how, what kind of diagnosis he had, or nobody explained to him in detail what exactly is the issue or the problem. So we give him an application through which he can actually find out what is exactly his readings. Does he need an annual screening, like a standard annual screening once in 6 months or once in a year, or he requires individualized screening, okay, depending on his condition. So we are developing, or we have rather, in the process of finalizing certain methods for risk prediction and visualization to not only give clinicians this big picture, but also to the citizen, to the patient, as to what is happening in his eyes. I think it gives a good perspective to the patient and gives him a feeler, as to what is happening, not only in his eyes, but overall diabetes, so that he can take corrective actions. So our solution, it works like this. We have a camera, a Wonders camera, which is integrated with our backend solution. And we call this as a product as a service, because camera is not sold as a separate hardware equipment, as opposed to the traditional way of selling these cameras. So we found out that this is not the way to go, especially in the tier 2 towns and rural areas. So we go to the primary care provider and give him end-to-end solution. We say that we give you the camera, we give you the backend, we give you the application, everything. And there is a subscription fees to that. And the primary care physician or even a diabetologist does not have to worry about buying a camera and worrying about its maintenance or upgrading of that piece of hardware or software, and talking to one vendor for software and one other vendor for hardware. None of that. So this is what we call it the product as a service, and it works like this. We have, this is our setup here. This is a live setup in Ulve, and the operator takes an image of the patient. There's a specialized application which is running on the laptop. You can see, and I'll show you a little bit. I have a small demo. Before I show you a demo, just give you a little heads up on this. And this image actually is sent through an API through our backend, which includes a retinal image quality checker. So if somebody sends a garbage image or not a very good quality image, the image gets rejected. Or obviously the diagnostic service, and then this image, once it is passed by the retinal image quality checker, it goes through our diagnostic service, and we use deep networks such as Efficient Net and some similar architectures. Obviously, trained on our own data sets and some publicly available data sets. So the back we have this diagnostic service, which is running on a infrastructure, and we have the model server, which has a repository of different models. So we have a model for diabetic retinopathy, different model for macular edema, glaucoma, AD, and so on and so forth. And then we also have through this API, we also have a module for user management and doctors' prescription management, so that we can monitor the conditions of individual patients. And we have a which generates and stores all these documents for any future references, and of course we have a data store. Now, to give access to this information to doctors or patients at any time, anywhere, we have a mobile client where a user can log in and find out his condition or his latest prescriptions. He can also log in through a browser, and this is available using all kinds of privacy and safety mechanisms, so that the data is not, even a doctor will not be able to look at any patient's data without the consent. So all these mechanisms are built into it, so that we don't violate anybody's privacy or safety. This is our report, and then I will show you. I will show you a small demo. Now, this is one of our outreach clinics where we have deployed this. And just give you a little bit of background on this. We have a tie-up with a local hospital called the King Edward's Memorial Hospital in Mumbai, who have given permission to us to do these screenings in their accredited urban healthcare centers and some community centers. So we have set up in these clinics and collect information and data from these clinics. So we have the doctors who are on board with us, who help us in clinical studies. So I'll just give you a small little demo on what is happening in one of these clinics.
I am Soumya.
Can you hear me right now? Huh?
Yeah. Yes, we can.
Through end-to-end SwastEye demo. The retinal image acquisition is done by using the fundus camera, as you will see in this demo. Camera is integrated with our SwastEye backend. As soon as the image is captured, the camera sends the image to our backend AI engine for diagnosis and report generation. Diagnosis, report generation, and sending report to the doctor all happens within 60 seconds. Report is interpreted by the doctor by taking into consideration the diabetes history, age, and other symptoms of the patient. If the patient is referred to the retina expert, then his case is monitored for follow-ups.
Yes.
I am sorry.
All right. I'll just run this very quickly one more time.
I am Soumya. I will take you through end-to-end SwastEye demo. The retinal image acquisition is done by using the fundus camera, as you will see in this demo. Camera is integrated with our SwastEye backend. As soon as the image is captured, the camera sends the image to our backend AI engine for diagnosis and report generation. Diagnosis, report generation, and sending report to the doctor all happens within 60 seconds. Report is interpreted by the doctor by taking into the diabetes history, age, and other symptoms of the patient. If the patient is referred to the retina expert, then his case is monitored for follow-ups.
All right, I'm sorry, the thing is stopping. Just give me 1 second. I just.
Absolutely, no worries at all.
Yeah. Yeah, I mean, the video stopped, somehow in the middle. So I was going to just explain, once you did, the doctor or the operator, he clicks on the submit button, it goes to the back end, and the report in less than 60 seconds. So the report can be given to the patient right when the patient is sitting in front of the doctor. So there is no question of coming later, coming after 1 week or 10 days, because we feel that once the patient goes out of the clinic and he does not have a report or a diagnosis in his hands, he pretty much loses interest, and the chances of coming back for second screening will be less. So giving a report right in his hands while he's sitting in across from the doctor is a very important aspect, which we have learned from many other similar projects which were done by Google and other companies. So that is one aspect. The second is this report does not go to the patient directly in any ways. I mean, we're not supposed to give this to the patient in their hands. It is always submitted indirectly to the patient. So a doctor is always in the loop, and he takes a call depending on the history of the patient, the age, and the duration and things like that. So yeah, that's it. I mean, I think my time is running out. So if there are any questions, I'll be happy to
Sure.
take them right now.
Yes. Thank you, Dr. Zia, for that insightful presentation. We do have a couple of questions. The first question says that, what are the potential limitations to the development and adoption of AI models in healthcare? Dr. Zia, you here with us? So you're on mute.
Yeah, sorry. Yeah. Could you please repeat it?
Yeah. So the question is that, what are the potential limitations to the development and adoption of AI models in healthcare?
Well, the main obstacle is that these AI models have to be certified by regulatory agencies, by associations, medical associations, and unless we do that, we will have obstacles in scaling it up throughout the country. But as far as our lab studies are concerned, and limited work which we have done in the field, we personally believe that our AI model is as good, if not better, than diagnosis of an ophthalmologist. Now, second aspect of this is the issue of how do we explain these findings? Okay, how do we explain the diagnosis? So the explainability issue is still an open issue, and I think it's an open many sectors in the domain of AI. And we are working on it. We are working on frameworks where very soon we'll be able to explain how this AI model has arrived at a certain decision. So if we can tackle these two issues, one is of regulation, the other one is of explainability, and I think there's no limit to where we can deploy this and how many places we can deploy this. And also please note that this algorithm is trained on data which is very heterogeneous. I mean, we have taken data from all over public sources, this and that. So it is in India. This AI model might work in populations which are in other parts of the world as well.
Thank you for that, Dr. Zia. Our next question says that instead of fundus camera, can a simple picture clicked from mobile phone be processed through pipeline of AI algorithms on cloud or edge computer for diagnosis of diabetic retinopathy. Mobile cameras getting more powerful pixel-wise as well as focal length-wise. This can actually bring down the affordability of such equipments to common man. So what are your thoughts on the same?
Yes. It's a very good question. I mean, I somehow skipped that in my talk. Fundus, mobile cameras are being used for capturing fundus images. However, you cannot use a mobile phone as it is. You still need an optical device coupled with this to be able to take the retinal image. The reason being, the optics of this camera is pretty complicated. The reason being, your inside of your eye is not self-illuminated. It's a dark part of the eyes. So you have to illuminate the eyes as well as take an image. So in optics, they call it illumination subsystem and imaging subsystem. And they have to be coaxial. So there are a lot of optical design, which is, so obviously, if you use a mobile camera, smartphone camera, your price will come down definitely, but still, you still have to design that optical part of it. So that's a challenge we are facing right now. We're in the process of designing that.
Thank you, Dr. Zia. Our next question is that what are your thoughts that will some embedded system module equipped with AI make the job easier for doctors? Yes.
The one possibility is that right now what we are doing is the of the AI is being done in the cloud, on the cloud. Is there any way we can bring that inference engine from the cloud to the camera itself? What we call as edge AI, and that is the next step we would like to explore. Can we bring the whole inference, the AI part, onto the camera, so that there's no need for any internet connection? That would be a new way forward, but we haven't delved into that yet, although it is in our roadmap. But certainly it will help. It will certainly help.
Our last question for you is that how can AI be helpful in the case of cataract or any other related surgery?
Yes. Well, the is what we call as the anterior part of the eye, whereas the retinal disease is the interior part. So even cataract sometimes is not visible to the naked eye. Okay, so these cameras actually can help detect cataracts in those eyes where the cataract is right, in the beginning stages. So in addition to what I mentioned about diabetic eyes, cataract can also be detected using fundus cameras with a add-on adapter which is required to actually take an image of the anterior of the eyes. So it is very possible using the same setup.
Noted. Thank you so much, Dr. Zia, for those for helping us answer those questions. And in case we have any more questions, from our audience, we'll drop an email to you with those questions, and then whatever your reply will be, we will forward it to our audience.